Good afternoon. To be mindful of everybody's time, we're going to go ahead and get started. We might have some other individuals that will be joining us, and we'll welcome them. Today's discussion is from the Virginia Assisted Living Association. We are going to be discussing Virginia's COVID response related to assisted living communities. As with any of our presentations with our large groups, we want to make sure that we keep in mind antitrust reminders and that we make sure that we're abiding by all the laws and regulations. We do not want to sharing any discussion or agreements or concerted actions that may restrain competition. So we just like to make sure to remind everybody of that, even though this discussion should not go anywhere in that direction. Couple of housekeeping and disclaimers. Please mute your line when you're not speaking. *6 can be used to unmute telephone lines. You can also raise your hand to be unmuted by a host. And we also invite you to use the chat feature to share any questions or comments. We will be monitoring the chat and the question and answers. Discussion is being recorded to be shared on VALA's Health Alert webpage. So we will be having this available later on this week. And that way, if you have any colleagues or anybody that you think might benefit from today's discussion, you'll be able to share the link with them once it is made live. Statements and information shared today are a work in progress, and so they may change. As with a lot of the situations going on, we know that we've had to be fluid in order to make sure that things are current to the best of our knowledge, and so just keep that in mind, that some of the information may be in an adapting progress. Few websites I want to share with you as resources. In just a few moments, we'll post a link to these slides in the chat function, and you'll be able to download it. But it will have active links as well to our VALA, the Virginia Assisted Living Association Health Alert webpage, the Virginia Long-Term Care Task Force webpage, as well as the Virginia Department of Social Services. On each of their pages, there are additional links and resources to a variety of agencies and support opportunities. Special guest with us today, we've invited the Virginia Department of Social Services to participate. We know that we'll have Tara Ragland, the Director of Division of Licensing Programs, Kathy Peterson, Licensing Consultant with the Division of Licensing Programs, and Lee Burke, Licensing Administrator with the Central Regional Office. We also have with us from the Virginia Department of Health, Sarah Lineberger, HAI Program Manager, Carol Jamerson, Nurse Epidemiologist, and from the Virginia Department of Medical Assistance Services, Tamara Whitlock with the Deputy Director of Complex Care and Services, and Chris Gordon, Deputy for Finance and Technology. Each of these agencies may also have additional staff members joining us today to help with any questions or comments or updates. Preliminary discussion agenda that we'll be covering today: reopening operations, testing updates, personal protective equipment, infection prevention and control assessments, funding opportunities for assisted living communities, and then any other additional COVID response updates or questions that you might want to share. So with that, I'm going to turn it over to our team. The first topic that we'll be discussing is reopening operations, what's required and what's recommended for assisted living communities here in Virginia. So with that, I turn it over to the Virginia Department of Social Services. Thank you.
Good morning or good afternoon, everyone. This is Lee Burke, Licensing Administrator, Central Regional Office. Happy Monday. We want to talk a little bit today about some of the things that we're working on to provide information to the ALFs in terms of our recommendations for reopening. I don't know, and move to the next slide. One of the things that we're going to be recommending to all of the assisted livings, and Tara Ragland has spoken on this before, is developing a mitigation plan for your facility. The components that we're going to ask to be put in this mitigation plan are listed on the screen: testing and screening, infection prevention and control, PPE, staffing, cohorting and designation of space, and communication. We are putting together documents to help assist in this, and within each of these categories in the mitigation plan, we are going to provide links, recommendations, additional resources so that you can develop the best plan for your facility. we have such an array of different types of facilities that cover under the ALF umbrella that it would be very difficult for us to do one of these for you all and tell you what specific things you need to do, because every ALF is different. We have ALFs that have 4 residents that only focus on mental health, and we have ALFs that have 250 residents. So each facility needs to adapt this plan based on the population and the size of the facility that they serve. Okay, next slide. We are going to recommend for larger facilities a 3-phase approach, similar to what VDH is recommending, and we're doing that applicable to facilities that are licensed for residential and assisted living level of care. And again, because we have so many different types of facilities, a facility licensed for 4, 8, or 16 people may not be able to appropriately implement a 3-phase approach to transitioning through different levels and of reopening. So larger facilities that have more visitors, more home health, a larger communal dining, it's going to be more appropriate for that level of care than it is going to be for residential only. So in these recommendations that we're going to provide to you, we're going to break down what we recommend moving between each phase. Okay, next. Additionally, what we're working on is 1 or 2-page tips and best practices. We are developing one for beauty and cosmetology services, visitors, communal dining, communal activities, transportation, COVID and secure environments, COVID and mental health, and within that, there'll be 2. So a mental health focus for staff and residents, and then 1 directed at residential only facilities that serves more of a mental health population, and return to work for healthcare providers. We've done these independently, so if there's a particular topic you may need, you can go and pull that off of our website and just use what information that you need. These are going to be ongoing, and as we get information from ALFs about what their needs are, we'll continue to create these and send them out to you all and post them on our website. So again, you know, these topics that we're talking about are going to be ongoing. We're going to continue to add more topics based on what you all tell us that you need. That part is extremely important, so we get you the information that you want and that you're going to find most useful. The mitigation plan is a framework for you to use, and when we send that to you, will probably be in a Word document, so you can add what you want to within our framework. Our format is not necessarily required, but we are definitely recommending that you put all of the components in there that we have listed in our plan. Does anyone have any questions about that so far?
Good afternoon, this is Kathy Peterson. I'll be going over the point prevalence surveys and where we are with that with assisted living facilities currently. To date, we've had approximately 50% of assisted living facilities in Virginia complete that have voiced an interest or have pending baseline PPS. We are currently working with VDH to establish further testing strategies to accommodate the remaining 50% and ongoing testing for assisted living facilities. They were a huge help to us, VDH and the Virginia National Guard, in completing the 50% that have already conducted their baseline testing. So we do appreciate them for helping with that effort. And as I said, we're working on strategies on moving forward to establish baseline and further testing for the facilities. And we'll also have our inspectors in each region. They're going to begin reaching out and conducting some needs assessments with the assisted living facilities to find out, more about testing and how we can move forward helping them, and what are some of the issues that they are having. And that will also, as Lee mentioned, help us create some additional not guidance, but additional recommendation for you all. And we'll begin putting those into some documentation that we're going to be posting on our website and getting out to you all as well. Okay, next slide. Wanted to talk today a little bit about PPE and the supply availability for assisted living facilities in Virginia. We have been asking and strongly encouraging all assisted living facilities to report their weekly burn rate and their inventory that they currently have on hand on a weekly basis, with the reports being due each Tuesday by 5 p.m. I've included the link that this is taking place on the slide. We also have that posted on our website as well. What this does, it enables us to work with with VDEM, the Virginia Department of Emergency Management. They are helping us with our PPE distribution. They also have set up, when you report this information, it allows us to have a baseline for what you have in your facilities, that if a critical need does come about, we're able to pull that data and help you to get the PPE that you need at that critical point. It also monitors on a weekly basis your PPE inventory. And what that does, I think some facilities have said, well, I'm reporting on a weekly basis, but I may not be getting any PPE. VDEM has set up a very intricate algorithm that when this information is reported in, they're looking at your inventory, they're looking at your burn rate, and that algorithm automatically will report out if there's a critical need shortage that is currently happening or that may happen within the next week based on the numbers that you report. From that is when the PPE is pushed out. And as most of you know, we do, I'm really hoping that everybody knows this, that we do have weekly regional PPE distribution based on those that are reporting. So on an average, we have about 283 of the 565 assisted living facilities that have reported thus far for July. That's roughly half of our assisted living facilities. So we really encourage you all to report, to do your weekly reporting and your weekly burn rate. I know that we have a lot of reports coming from a lot of different angles, but this will really help you in the event that you enter into a critical need or you are experiencing an outbreak in your facility. Okay.
I do see that there is a question on the chat about, will you please clarify if testing is required or recommended?
Okay. We are recommending, and we are strongly recommending testing for all assisted living facilities. We are working in conjunction with VDH, and so that we all have a united front as far as the long-term care facilities go. But without federal mandates and such, as we cannot require that, but it is strongly recommended in your reopening guidelines and moving forward. Okay, I'll speak on our end of the fit testing, and then I know that VDH will step in and speak to this as well. VDSS is working in conjunction with the Virginia Department of Health to offer additional train the trainer sessions for N95 fit testing. It's our goal to have a trainer trained and available in each facility to do the fit testing of N95 masks. This training and these sessions are free of charge. Registration is required, and fit testing kits are available for use at the training sites. We are aware that there has been a shortage of fit testing kits. Hopefully with the production getting back and getting started, that we will see an uptick in the availability for these testing kits. But for now, I know that VDH has been working with their folks, but we do have some loaner testing kits in our regions, and we'll be pushing that information out this week in reference to how to obtain a testing kit so that you can have your facility fit tested and have your staff protected as well. I don't know if VDH wants to go ahead and put their spin on this as well.
No, this is Sarah Limburger. I think that's all we were going to mention as well, Kathy. So thanks for going over that.
You're welcome.
There is a question in the chat, and I know that the National Guard has helped with some of this, but is the National Guard still testing, and if so, for how much longer?
The National Guard, go ahead. Sarah, were you going to say?
Go ahead, Kathy.
The National Guard, their mission was complete last Thursday. So I believe that as far as what they were doing and their presence, that they have completed their mission. And Sarah may be able to speak a little bit more to that.
Sure, this is Sarah Limburger. The National Guard did complete their mission for conducting point prevalence surveys in nursing homes. However, VDH is still committed to continuing to conduct point prevalence surveys in assisted living facilities from now through the end of August. Some of the details in terms of who is going to be doing that, whether we can extend the National Guard a little bit longer or whether we'll contract with someone else to do that testing, that's sort of being worked out. So I don't have a final answer on that, but we are committed to doing those point prevalence surveys with ALFs through the end of August. We already have a list of over 100 additional ALFs who've expressed interest in conducting a point prevalence survey over the next month or so. But if your facility isn't on that list, then we could probably add you. And I will put an email address in the chat. And if you haven't expressed interest in doing that, then you can reach out to this VDH email and express interest in doing a point prevalence survey with VDH.
I do see some additional chats, but we'll also save some of those for at the end to see if any of the other information is covered. Right now, we'll go into infection prevention and control assessments.
Carol, are you on the line?
Yes, sorry. Thank you, Sarah. So to date, we have completed 199 infection prevention and control assessments in July. And thank you so much for everyone who has participated. As you know, we had federal teams that were represented by nurses, specifically trained in infection prevention from the VA hospital. Hospitals across the different states come and help do this project with us. And I think we've learned a lot from it. We are compiling the results as we speak. We had a daily debrief with the teams each evening to really address burning questions and try to, anything that was of importance to be answered right away, we tried to get answers back quickly. But the results of those surveys will go to the local health department, and also a copy will go to the point of contact at the facility that was surveyed. We identified some interesting gaps, and they will help us guide program activities going forward, looking at specific education and training activities that are needed, as well as identifying different areas and different regions in the state that have more targeted resource needs and education needs. Next slide, please. So some notable findings, I think with no surprise that PPE remains a struggle. People are continuing to have to extend use, reuse N95s, come up with creative ways of having those decontaminated, including the use of the Patel system. Gowns continue to be in short supply, in some areas more than others. We've already discussed the need for fit testing and respiratory protection education, and we're hearing that particularly small size respirators are more of a need than other sizes. We're hearing that cohorting practices continue to be confusing, and we don't disagree with that because not everyone's geography and their facility is the same. Some people are dealing with private rooms, some with semi-private rooms, some with couples that live in the same room. So it continues to be a challenge for cohorting practices. Also, we're finding that simple things that we thought were pretty well understood, like universal masking, the social distancing, restriction of visitation, are not well understood in all areas. There are people that have done very creative ways to address this, and we're thankful for that, but we're also realizing that there are others that have less of an understanding of what it is meant to really implement. We feel like that the hand hygiene and proper PPE and doffing is understood in many places, but there's not competency checks or validation of those practices. So many people have spent a lot of time doing great work and educating, but they're not giving themselves that credit for auditing those practices to really prove that they are validated and put in place. Environmental cleaning and disinfection needs remain to be reinforced. I think the product list is very helpful. There's a long list on the EPA website, and people, I think, know how to go to that. We're hearing that they are using the list, but the dilution and the dwell time is often not applied appropriately. And as we all know, chemicals only work when they are applied and used per manufacturer guidance. So reinforcement there is needed. And as always, we're continuing to get lots of questions about safe communal dining, pet therapy, visitation outside for visitors, and cooling fans, particularly now that it's become hot. We have frequently asked questions available that address many of these questions, and some of the specific questions, particularly related to cooling fans, we've reached out to CDC for additional guidance. Next slide, please. And so now we're going to move into talking to some pretty important updated CDC guidance documents that came about on July 17th. And these guidance documents are addressing return to work criteria for healthcare personnel and the discontinuation of transmission-based precautions and the disposition of patients with COVID-19. So it's important to know these guidance documents are applied to those particular elements, so to healthcare personnel and to residents that have a COVID-19 diagnosis. And the summary that drove these changes, or the rationale for these changes, is included in a CDC decision memo, and the links for all of these documents and that decision memo are noted on this page. It's a really good document to read, the decision memo, that is, if you need to really have evidence to back up some of the things that you're saying to people about the transmission of virus and how long the virus is competent to be replicated or transmitted to someone else. So the CDC decision memo really addresses patients with mild to moderate COVID, as well as patients that have serious or critical illness or severe immunocompromised conditions. And it's stratifying the difference in those areas of illness so that the appropriate time for precautions or staying out of work is applied based on that level of risk of illness. So the big change, and we can go to the next slide, please. The big change for return to work for healthcare personnel is that now, except in a rare situation, a test-based strategy is no longer recommended to determine when a healthcare worker can come back to work. And for most persons with COVID-19 illness, the isolation and precautions generally is discontinued after 10 days of symptom onset. The next change, and I'm sorry, I'm skip by a point, for those patients or those healthcare personnel with severe to critical illness, or those that have severely immunocompromised conditions, and those conditions are defined specifically in the guidance document. The recommended duration for work exclusion for those folks is extended to 20 days. Again, most people will not fall in that particular category. But other symptom-based criteria that has been modified is the definition of the timeline for fever. So it has now been changed from saying at least 72 hours to at least 24 hours have passed since the last fever without the use of fever-reducing medications. And the wording has changed to say improvement in symptoms, whereas it used to say improvement in respiratory symptoms. And that's because the expanded list of symptoms associated with COVID-19 has changed. Next slide, please. And this is pretty much the same language in the document that is addressing the discontinuation of transmission-based precautions. It's using that same recommendation timeline, and again, for patients with mild to moderate illness who are not severely immunocompromised, it now says at least 10 days have passed since the symptoms first appeared, and at least 24 hours have passed since the last fever excuse me, without the use of fever-reducing medication, and the symptoms have improved. Next slide, please. So, sort of key notes to remember when thinking about discontinuing transmission-based precautions. You need to review the guidance document to understand the complete description of the discontinuation of transmission-based precautions. It's now using more of a time period, and it's grading it based on the patient's severity of illness. And the decision memo really has great information about supporting why this change has happened. They've looked at all the data that they have accumulated since mid-July, and it obviously reflects the evolution of the pandemic. Things have changed, and we're learning more. And CDC is continuing to monitor this evolution of the science that's needed to drive this data. We are reflecting these changes in our guidance documents, but to reassure you, if you look at our reopening guides, or if you look at our long-term care guidance document, all the information that we have posted, it links to the discontinuation of transmission-based precautions, and that takes you to the most recent guide. We have a little bit of wording that we're going to change in their long-term care guidance and perhaps put in an informatic or a picture graph that can be used maybe even in several languages that can be posted for people to refer to. And next slide, please. So one of the most frequently asked questions that we get is a person who previously tested positive, clinically recovered from COVID, later tested again. If that person tests positive by PCR, should they be managed as a potentially infectious patient to others, and should they be isolated again? So we've included this slide so you will have the verbiage for our answer to this particular question, because what we're saying is it's not necessary during the first 3 months after the date of symptom onset to retest a person. Again, in the decision memo, it goes a little bit more into how recovered patients can continue to shed that virus in their upper respiratory secretions for up to 12 weeks, but there is no documented case of this virus causing reinfection. So in other words, the virus may be present in the PCR test, but that person is no longer considered infectious after that particular timeline, either the 10 to 20 days, depending on which risk category they fall in. Also, we're saying in this question and answer that if this person does become ill, they do have symptoms that suggest COVID, that we would consider consultation with an infectious disease doctor specialist or public health experts to really look at their whole medical history to determine do they have another alternative illness that could be causing these symptoms. Again, anyone who is determined to be potentially infectious should undergo evaluation and remain isolated until they can meet the criteria for the discontinuation of transmission-based precautions. We're just not recommending that they be retested. This is verbatim from what is on the CDC's FAQ page for clinicians, but we just wanted you to know that this particular question does come up, and we have addressed it in our FAQ as well. And I think that's it for me. Next slide, please. Let me make sure.
Next is the vaccination update. So if we want to pause to see if there's any questions or comments on the topics that were just discussed, please remember you can use your chat box. You can also do *6 and also raise your hand, and we can unmute your line if you'd like to speak audibly. One update here as well is that VALA is working with other associations, including the Virginia Hospital and Healthcare Association, the Virginia Healthcare Association, and Leading Age Virginia to update the guidance document on transfer of individuals from the hospital settings to a long-term care setting. And it does reference the transmission-based precautions in order to be able to do the transfer safely. So we hope to have that out within a week or so. That we are updating that as the previous information has changed from the CDC and from the Department of Health. So we'll keep you posted as that is available. But if you have any questions, please remember to use the chat or other features. Thank you.
Hey, it's Sarah Lineberger at VDH, and I am going to present a few slides on vaccination from Christy Gray, our Division Director for Immunization, and I'm happy to take specific ALF-related vaccination questions back and get more information if needed. This month, August, is National Immunization Awareness Month. So this is an annual observance held in August to highlight the importance of vaccination for people of all ages. And CDC does have a website with a wealth of resources on vaccination. I was actually just looking at it a little bit ago, and there is some helpful information. There are some videos about how to handle hesitation around flu vaccination and other things like that. So if you're looking for general vaccination resources, this is probably a good place to start. Next slide. this slide isn't as relevant for you all. Basically, this slide is saying that from the VDH perspective and local health department perspective, we're really trying to finish planning for flu season. And as well, we have a whole team planning for COVID vaccination whenever that may be. And the general message is that if you are planning to vaccinate in your facilities, then now is the time to start planning. As you know, there have been many different supply chain issues as we've moved through the pandemic, and there's a feeling that supplies for vaccination that you would need to vaccinate, not just the vaccine, but just supplies that you would need to do the vaccination will potentially become scarce as more and more people are planning vaccination. So if that's something you typically do in your facility to vaccinate residents and staff, and you haven't started planning, I would encourage you to go ahead and do that and try to secure supplies. Next slide. So my computer might be behind, but can you go to the next slide? Yes, so just to reiterate that influenza vaccination is more important than ever. This flu season, we anticipate that we'll have flu and COVID circulating at the same time, which will present a variety of challenges. In your facility, I would go ahead and start planning for that. And I would also just reiterate that, you know, often in terms of work we've done in the past with nursing homes and assisted living facilities, often a significant proportion of residents are vaccinated for flu annually, and often staff, the percentage of staff in nursing homes and assisted living facilities is much lower. However, because we're in the middle of the pandemic and because these staff are working with residents who are at higher risk for flu complications anyways, I'm really trying to reiterate the fact that flu vaccination for everyone is very important. And so even if you don't vaccinate at your facility, it would be great if you can do messaging to your staff members about the importance of vaccination and that sort of thing. And if there are other resources needed specifically for ALFs, I'm happy to work with you all and work with Christy on that. Next slide.
Sarah, I do want to pause for just a moment on this, and with regards to our conversations with the other associations and on the vaccination of staff members as being very critical so that it doesn't cause an additional shortage of staff members that might have to go out for the flu that they might have a suspected COVID case. We think that that's very important to emphasize with providers to make sure that you want to try to eliminate the flu as causing any COVID possible symptoms so that it doesn't cause you to reduce your staff due to quarantine measures. And we are working on a survey with the other associations with regards to vaccination of flu for residents and employees in assisted living and nursing home communities. We have a lot of data on nursing homes, but not necessarily on the vaccination of staff members in assisted living communities. So please watch for that as well. I know that everybody's done a lot of surveys, but we appreciate, you know, a little more information on this since we don't have anything.
Yeah, I would definitely agree with all those comments. We started looking through a chart of symptoms, of influenza symptoms versus COVID symptoms versus the common cold, and it's going to be a challenging fall season to know sort of what's circulating in facilities based on symptoms alone. So there will be the need for testing, but the best thing we can do is vaccinate, at least for the illnesses that we have vaccine available for right now. And this slide isn't as applicable for ALF since it's talking about vaccination for children, but just again to reiterate the point that Judy was making, overall we've seen routine vaccinations decrease during the pandemic, especially for a couple childhood, sort of regular childhood immunizations, and we think that's just because people have been staying at home and not seeking medical care during the pandemic. So again, thinking about your staff, those with children, et cetera, it's just really important to emphasize routine vaccination for everyone so that we don't see outbreaks of any other vaccine preventable diseases. So just wanted to mention that as well while you're thinking about staffing, et cetera. And I think that's all I have for vaccination, Jeannie.
That is the last slide for vaccination. So are there any questions or comments from the participants regarding this? The next topic we'd like to discuss is with regards to funding opportunities for assisted living communities.
Thank you. This is Chris Gordon from DMAS. Can you confirm that you hear me?
We can hear you. Thank you.
Okay, perfect. What I wanted to, I am mindful of the time that we have about 16 minutes left, and I want to just emphasize, number one, that DMAS is your state Medicaid agency, as you're well aware, and all of the things that you've heard both from our sister agency, the DSS, and the Virginia Department of Health are critical, important public health measures to assure control and prevention of COVID-19. Almost more important than all of those efforts is the funding necessary to support those activities. So all of these are excellent opportunities or strategies to mitigate the pathogen. However, without that, without funding to support these efforts, it becomes very challenging. And so to that end, the administration back in June announced publicly that they were going to provide CARES Act dollars for not only nursing facilities, which we've supported from the very beginning, dating back to March, but also for assisted living facilities. And so to speak on this, I brought my staff member, Thomas Gates. He's my senior finance and technology advisor. He's going to be sharing his screen and providing a quick update on his efforts and outreach and where our agency is to provide financial support to all of the ALFs so that we can make sure that you all have the resources you need to make these strategies realistic and successful. And I'll turn it over to Thomas.
Thanks, Chris. So we'll see if the screen sharing works. Sorry, I just threw together a couple of slides just to try to make it a little bit easier to walk through this. Did that work?
Yep, we can see it.
Fantastic. Okay, so just going to go kind of high level through this. You guys probably saw some of this from the press release or from some of the communication from some of the associations. Essentially, the specific thing for the assisted living facilities, as opposed to the nursing facilities, is every facility, I think we have 566 listed. I think I heard VDH say 565, but each facility is eligible for a monthly payment of up to $4,000 for each of the months covered by the program. And so this program is being run July, August, September, and October. So $4,000 a month for each of those months. An additional daily payment is available for each facility that has auxiliary grant recipients, which my understanding is that's roughly half the assisted living facilities. And that would be based on your census of auxiliary grant residents. So you would get $15 per day per AG resident. And the important thing to kind of caveat here is that this is not, it's not a rate. It's not a payment based on just this calculation. You know, you raise your hand, say I'm a facility, I get the $4,000. Based on the CARES Act rules and how the program has been constructed, the payments are only eligible for demonstrated and invoiced COVID-19 costs. So that would include things like testing, staffing increases that you have to do, PPE, cleaning supplies, a lot of the things that we've been talking about on this call with both DSS and VDH would be eligible costs, but you do have to document those costs and share that with DMAS to be paid. So The $4,000 and the $15 per resident are really more of a ceiling or a cap on what can be invoiced, and not a kind of blanket payment, if that makes sense. So I'll just jump. The only other thing I wanted to cover was just, let's see if I can advance the slide, just to walk through the schedule. So this has been moving pretty quickly from a government perspective. We are trying to set up some contract support to help us deal with the invoices that we would receive, getting people enrolled, doing the communication out. So we are in the process of doing that right now. If you kind of walk through the schedule, July 1st is when eligible costs can start being incurred. So anything that you have incurred during this month that falls into that category of additional costs for PPE, for staffing, cleaning supplies, things like that, please save the receipts, save your documentation, because those costs would be eligible for reimbursement under this program. This week, we're actually hoping to award, I think we will award the administrative support contract, which is going to let us really ramp up the speed with which we are beginning the outreach to you, getting people enrolled, and then eventually making those payments. So we're excited to get the support on board and then really start moving more quickly out of the planning and into the kind of implementation phase of this. In early August, you should be getting communications from, probably from us, or maybe from the vendor, on exactly what the process will look like for submission, for the necessary documentation you need to support those invoices, how to get enrolled, things like that. And then by mid-August, we will start accepting invoices and getting facilities enrolled. It's important to note, you guys are all probably aware of this, since Medicaid, the Medicaid agency, DMAS, does not currently make payments to assisted living facilities, all of you will need to get enrolled into our system as providers or vendors so that we can then make payments to you. So that will also be part of that kind of initial communication is, here's the information that we need, here's where to send it. We will be hoping to enroll everybody as vendors and also at the same time enroll you for electronic funds transfers so that we can make electronic payments to you after we start receiving those invoices. So then past August, we're looking at late August, early September to begin making payments. And that really depends, this is all subject to change. And that really depends how quickly we're able to get people enrolled, how quickly we're able to get those invoices. One of the keys for CARES Act funding is that it disappears on December 30th. So we have to incur all of our costs, do all of the work before December 30th. And because of that, we are going to be doing an enhanced review of invoices as they come in, but we will not be doing any kind of recovery audits or at least through this initial program. You know, I can't speak for the U.S. Treasury Inspector General, who will be auditing the CARES Act program in general, or other kind of more broadly scoped audits. But as a part of this program, we won't be doing kind of a reconciliation process at the end. And that's really based on the timing. And so we will be doing a more kind of robust invoice review at the beginning. And I just say that to say that the initial payment date could change a little bit depending on what that invoice review process ends up looking like and how long it takes. And we'll know that soon once we have more kind of detailed conversations with our vendor. October 31 is the end of eligible costs. So we can't pay for anything that you incur after October 31st or incur before July 1st. And then we're looking for final documentation by December 1st. And we're aiming to make those final payments by the end of December. Treasury has provided some guidance in the last couple of weeks that payments can be made into January. And so even though you can't incur any new costs past December, we may, again, depending on kind of what that invoice review process looks like, we're shooting for paying by the end of December, but we're kind of holding back the possibility it could leak into January. So that is the kind of high level review of both what's eligible for reimbursement, how we're going to calculate the kind of per facility cap on what can be reimbursed, and then the general timeline for how to go through the process of getting enrolled and reimbursed for payments. So with that, I will stop sharing and see if there are any questions in the chat or elsewhere.
I do see a question in the chat regarding the CARES Act funding. Can you expand on what staffing costs will be reimbursed within the program? How will that be calculated? On what can be submitted for reimbursement?
So I think we'll have more guidance probably in that kind of initial communication on exactly what can be reimbursed. But I think the general principle is you have to be able to tie it to COVID-19. So to the extent that you are bringing on additional costs, additional staffing to do, I don't know if you do your cleaning in-house or something, and because of enhanced cleaning procedures that you've put into place, you had to bring on additional staff to do that. Something like that, where you can kind of tie directly to the COVID-19 as the reason for increased staffing. You could also probably tie overtime costs, things like that, where you have to be able to tie it to that COVID-19 cost. That's the requirement of the CARES Act. And again, like we will aim to have kind of more discrete guidance that's beyond these kind of general categories in that communication we're sending out.
And that would tie into the comment of list of invoice items. So that would definitely be helpful to have just some sample, of course, with every community being different on what's being expended. You may need to just be specific on how your community had COVID expenses. So that will be forthcoming information. Any other questions or comments from our state representatives of any other topics that were not necessarily in the preliminary agenda that you'd like to share that may have been updated?
Our Deputy for Complex Care, Tammy Whitlock, is also on the front from the Department of Medical Assistance Services. And I would ask her obviously to speak on some of the nursing facilities ALF efforts they've undertaken.
Tammy, you may need to do *6 if you want to speak. I know that there are some questions that have come in about, does a community have to have COVID cases to qualify for the funding that was referenced?
No, you wouldn't. Again, the cost would have to be related to COVID. So, I think it would have to still be something that you were putting in place as a preemptive measure or in response to, defer to my colleagues from VDH and DSS, but I assume our guidance is to do things preemptively and not wait for an outbreak. So no, I don't think you have to have an existing case, but the cost just has to be connected to your response to the pandemic.
And that was part of the discussions, is that a lot of providers, even though they did not have a COVID outbreak, they did take preventive measures in order to do infection control, increasing their practices to try to protect the residents and staff, purchasing of PPE supplies for their staff and residents. And so some communities still have not had a COVID outbreak, and we're glad to have that, but we want to make sure that all communities have some sort of recognition. So that's one reason why we encourage the state to include them also, not just the COVID outbreak communities. Another question that was put in is, when will information be emailed regarding the CARES Act? So I know part of that was covered on the timeline about releasing information as far as the reimbursement procedures, and that they'll be sent to all of the providers in order to share how to submit your reimbursements, what requirements of invoicing, and the specific timelines.
And we're aiming for early August. Obviously, we're bringing the vendor on board hopefully this week, and then kind of hitting the ground running, creating all that stuff to send it out the door. So giving ourselves the latitude of early August, but that is the goal, and we're going to be trying to get that as quickly as we can, but we want to make sure it's also anticipating and answering questions for folks and not just raising a bunch of questions the first time we send it out. So.
Remember, if you'd like to ask additional questions, I know that there are some chats coming through, but please use your chat or raise your hand if you'd like to do an audible question. You also *6 on the telephone lines. But there are some questions with regards to, is there a specific hazard assessment form that needs to be completed by an assisted living as noted in the Department of Labor and Industries Emergency Temporary Standard Infectious Disease Prevention? COVID virus that causes COVID. This standard was communicated in one of the updates. So DSS, do you have any updates with regards to that? The new DALI standards that were put out?
This is Lee Burke. We don't have any updates right now, but we'll look further into it and send a communication out.
Thank you. Any other questions or comments? As additional information is put out by the various agencies as the continued response, especially with regards to the Department of Labor updates and the funding opportunities, we will continue to provide updates on that. Be sure to check out the VALA Health Alert page, and that's where some of the links to the resources are constantly updated. If you have any questions and you want to reach out to any of these agencies, you may also contact me. I'm Judy Hackler, the Executive Director for VALA, and I can connect you with the various agencies as well if you have a question after today's webinar ends. I want to thank everybody, especially the state agencies, for participating, providing the information. We appreciate the partnership, and for the attendees for the questions that were shared. One last time for any last questions or comments from any of our state agencies or participants.
Judy, this is Kathy Peterson with VDSS. We would just like to encourage all assisted living facilities to review the VDALI information and the emergency regulations. Become familiar with that information. We will, as mentioned, follow up with, with some additional information, but it is important for you all, by another regulatory authority that you become familiar with those guidelines that VDALI has put out.
And Judy, this is Chris Gordon again from the Department of Medical Assistance Services. On behalf of Thomas and myself and Tammy, I just want to say thank you for the opportunity to present and provide this information. Certainly after the guidance comes out in August, we'd be more than happy to come back again and provide an update, answer additional questions, have a Q&A session, whatever you'd like.
We truly appreciate that. Thank you all for participating today, and we will again put out updates, and if need be, we'll do additional discussion webinars so that we can bring everybody back together for the latest updates. So thank you all. Hope you have a great day. Please let us know if we can help in any way.